Hey, thanks, guys. Nice to see so many familiar faces, and thanks, Dr. Betts, for including me. Um, I think both of these devices are really exciting. The infravertebral device, the VertiWedge, is one of these truly unique, truly something different type devices that I don't think it can be overstated how exciting that is. A motion sparing device that potentially treats not only the radiculopathy and vertical stenosis cases, but also potentially give you good deformity correction that's a really exciting prospect. And so I have a couple of cases here. These are both patients I've recently seen in clinic who I discussed this device with because I think they're good cases for it. The first is a 75-year-old woman who's coming in with right L3 radiculopathy and very little to no back pain. You know, when I ask her to kind of give me percentages of how much her leg pain versus back pain contributes to her overall unhappiness with her spine-related quality of life or her disability, she's, 95+% leg pain and little to no back pain. One key thing I think about her is that she's got good global balance. I know I don't show a lateral here, but she's balanced well coronally. She's balanced well globally. This isn't a huge deformity correction we would need to do for her. It's predominantly vertical stenosis compressing the right L3 nerve root. Trying to show that there on the coronal MRI view. In most of these cases, the ones that I imagine are going to be the best are the ones where there is asymmetric vertebral body collapse or remodeling such that on a coronal view, you've got a shorter end plate to end plate height on the concave side than on the convex side. I think those are going to be the sweet spot initially, at least for these cases, because that's what the procedure's doing is we're restoring, hopefully restoring symmetric vertebral body anatomy and therefore symmetric foraminal height. So of course, haven't done one of these yet, but I think this would be an excellent case for it. Next slide, Asher.
1 second. I'm not sure what's going on.
Does somebody else still have control?
Oh, sorry about that. My computer froze.
No worries. Here's another case I just saw last week, and patient's thinking it over. It's a similar case, 62-year-old woman, this time with left L3 radiculopathy, little to no back pain, not a huge deformity, good global balance. And as you can see on the coronal view of a CT abdomen and pelvis that she had done recently there's this sort of asymmetric remodeling of the vertebral body. And I tried to capture it as best I could on one slice, but you can get a sense of how small that foramen is on the left side at L3. You can see kind of where the sort of an osteophyte at the inferior end plate is forming and where the pedicle starts above. And so sometimes in these cases, if you aren't careful and you just get into the disc, you don't actually address that osteophyte coming off the inferior end plate. And you may expand the disc excellently, but if that osteophyte on the inferior end plate of the superior level is still trapping that nerve root, you still have a symptomatic patient. And the VertiWedge device, that procedure will directly address that height. So from a pure radiculopathy standpoint, I think this is going to be, I'm optimistic this will certainly be effective. From a deformity correction standpoint, I think it's going to be interesting to see what kind of corrections we get. I think the big concern from having done quite a few of these in the cadaver lab is there's a couple. One is that, do we keep people stable enough that they heal? And then two, especially in cases where there's a lot of collapse, it can be a little bit tricky getting the inferior screw into that sliver of bone left. But we've done quite a few of them in the lab, and successfully so. And so I'm very optimistic that from a procedural standpoint, this is technically something well within everyone's grasp of achieving. Just like anything, it's going to require some time and work. I'll stop there. It looks like maybe there was a question.
Michael, this is Raj. Can you hear me?
Hey, boss. Yeah, I can hear you.
How you doing? You're such a visionary guy. You know I love you, and so I think I think that you have hit the nail on the head. Right? There are a lot of patients that have deformity light, right? Who don't need a deformity correction but have a symptomatic radiculopathy, and I think you've shown two really great cases of where a single level operation is a really good option, but maybe a single level fusion is not a great option, right? So I think that I just wanted to highlight, a really nice case selection that you made for these to bring really this point forward that we're really treating just a single level radiculopathy.
Great point, Raj, and I agree. These are amazing cases for this.
By the way, I just want to say, Baron, Michael was one of the best fellows at Virginia Mason the last decade. So that's why I really thought I wanted to highlight him here,
Fantastic. Thanks for saying that.
He has a big conflict of interest, unfortunately, but
so Shirley has a question for you too, Michael. Why will the coronal plane mild deformity be a useful finding for vertiwedge? What about that deformity? Do you need the deformity to do this, or
I think
without the wedge deformity?
It's a great question. I don't think you need it, but I think this is a pretty common anatomical and clinical picture that we see, where somebody's developing to use what Dr. Sethi said, kind of a deformity light situation. And it's not at all uncommon in those cases for there to be concavity radiculopathy. And I can't tell you the number of times, and I'm sure you all have the same experience, where I have a case just like this, except they're on their 5th attempted microdiscectomy, minimally invasive foraminotomy, and they just, somebody just keeps trying to decompress a foramen that's got vertical stenosis, where the the nerve is getting captured between one pedicle above and another pedicle below, or a pedicle above and an osteophyte below, and what they really need is expansion of that foramen, and so you don't have to have a coronal vertebral body deformity, but it's very common to see that in this type of picture.
Great. And and my co-moderators, please feel free to take the mic from me. But the same question I had for Puya, is there a bone density, a T-score in which you would say, I don't think this is a good patient for this procedure?
Yeah, I think that this may be controversial. I find that DEXA scores poorly predict what I find in the OR. I'm much more of a Hounsfield units guy on the CT scan.
Yeah.
And so the short answer is yes, absolutely. I'm aware of bone density problems. I recognize that this isn't really the standard, but I've just seen too many high DEXA score patients, low DEXA score patients, where what I find in the OR at the critical levels is not predicted, for better or worse. And the CT scan tends to be a much better predictor, in my opinion, or in my experience, I guess. It's not to criticize anyone's use of the DEXA score. That's the quote unquote standard. But for me, if we're looking at one level, a lot of times there is bony sclerosis. A lot of times there is sclerotic bone at these levels that we're talking about. So even if they've got a pretty wimpy femoral neck, you may find they have pretty good Hounsfield units at the level we're talking about treating.
Okay.
Yeah, I actually agree with you. I tend to look at their Hounsfield units more when I do any kind of interbody work. particularly a standalone lateral. I guess my question to you is, what numbers do you hang your hat on? Do you look at do you look for this construct at both the UIV and LIV, I guess, as you would describe it in this situation? Do you look at L1? What Hounsfield's units are you selecting? I'd be the first to say I look at the levels that I'm treating.
Yeah, I agree. Just look at the level you're treating. I think everybody's kind of got their ideas about what number of Hounsfield units they like or don't like. I will say that one thing that I've been experimenting more with, that I've heard more senior surgeons and partners of mine using, are things like, and I think this would be perfect for this kind of thing in an osteoporotic patient, would be certain. Randy, are we allowed to use trade names in this? Is there any problem with that?
Yeah, no, you can do that. No problem at all.
So there are, bone cements or things like Montage is a specific one where it's sort of this quick setting putty that you could inject at the level you're planning to treat to give yourself a real solid surface in which to do your osteotomy work. I found that very helpful when I need to do like 3-column disc space osteotomies in an osteoporotic patient. It's real easy to do those when somebody's got real sclerotic end plates. It's a lot harder when the bone's all mushy. And so we've got some technologies now that help us make mushy bone hard. And it's likely that some of those products will be helpful in this type of procedure.